Your patient's heart rate is 48 and they are on metoprolol. Do you give the dose? Do you hold it? Do you call the doctor? Stick with me for the next couple of minutes, and by the end of this video, you will know exactly what to do and why. Hey, welcome back. If you're new here, I'm happy you found this channel. So beta blockers are everywhere. You'll see them in the hospital, you'll see them in clinics, and in long-term care facilities. They're one of the most commonly prescribed drug classes in all of nursing. So whether you're trying to survive pharmacology, you're cramming for the NCLEX, or you're already on the floor and just want things to click a little better, this is for you. Here's what we're going to cover: how beta blockers work, when to give them, when to hold them, what side effects to watch out for, and most importantly, what to teach your patients. So let's get into it. Okay, let's start with how they actually work. You have two branches of your nervous system. One is rest and digest. The other is fight or flight. Beta blockers deal with the fight or flight side. When your body thinks it's in danger, it releases adrenaline, technically called epinephrine and norepinephrine. These chemicals latch onto receptors that are called beta adrenergic receptors. When they do, your heart speeds up, your blood pressure rises, and your heart has to work a lot harder. So now here's where beta blockers come in. Think of them like bouncers at the door. Adrenaline tries to get in and fire things up, but the beta blocker is standing right there blocking the entrance. The signal never gets through, so your heart rate slows down, your blood pressure drops, and your heart doesn't have to work as hard. That last part is called reduced cardiac workload. This is the whole reason these drugs are important. For heart failure patients, for people who have had heart attacks, for angina, the heart gets a break. Now, there are two main types of receptors you need to know. You have the beta 1 receptors that live mostly in the heart, and beta 2 receptors that live mostly in the lungs and the blood vessels. That distinction matters, and we're going to come back to it. This is where a lot of students get tripped up. And honestly, it's where the NCLEX loves to set traps. So let's break it down. Beta blockers come in two types: cardioselective and non-selective. Cardioselective beta blockers mainly target beta 1, which are the heart receptors. They're not really touching the lungs. The big names here are metoprolol, atenolol, and bisoprolol. Because they're mostly leaving the lungs alone, cardioselective beta blockers are safer for patients with asthma or COPD. You're not blocking the airways. You're not risking a bronchospasm. Non-selective beta blockers, on the other hand, blocks both the beta 1 and beta 2 receptors. That means they hit the heart and the lungs. Propranolol and carvedilol are the ones you'll see most often. Here's the thing. If you block beta 2 receptors in the lungs, you can cause bronchoconstriction. That's a dangerous narrowing of the airways. For a patient with reactive airway disease, that's a serious problem. So remember this: asthma or COPD plus a non-selective beta blocker equals a red flag. We'll come back to that. One quick naming trick for the NCLEX. Beta blockers end in OLOL. So just remember this: your metoprolol, atenolol, propranolol. Whenever you see these names, know that they are beta blockers. So why do we even give these drugs? Let me walk you through the main reasons. Reason number 1, for hypertension, which is high blood pressure. Beta blockers lower heart rate and reduce how hard the heart pumps. Less force equals lower pressure. Number 2, heart failure. This sounds counterintuitive, but hear me out. If in the heart failure, the body goes into an overdrive trying to compensate. It floods the system with adrenaline. Over time, that actually makes the heart weaker. Beta blockers calm that response down. They protect the heart in the long run. Number 3, post-MI, meaning after a heart attack. Beta blockers reduce the risk of a second one. They decrease oxygen demand and help stabilize the heart's electrical system. Number 4, arrhythmias, particularly atrial fibrillations, also known as AFib. Beta blockers help control how fast the ventricles are beating. Number 5, angina, chest pain from the heart working too hard. So beta blockers reduce that workload. Number 6, anxiety. Propranolol specifically are one of the most commonly used beta blockers to help patients or help people who deal with anxiety. And it does not sedate. So it's non-sedative. It just blocks the physical symptoms, the racing heart, the shaking hands. So that's why a lot of performers often will take propranolol prior to going on stage. Number 7, hyperthyroidism. When the thyroid goes haywire, the heart also goes haywire. Beta blockers manage those cardiovascular symptoms, especially in a thyroid storm. Now, here's where it gets important. You need to know these side effects for your patients and for your exams. The biggest one is bradycardia. That just means slow heart rate. You're blocking the receptors that speed the heart up, so the heart rate drops. If it drops too far, it becomes a problem. Right alongside that is hypotension, which is low blood pressure. Less cardiac output means lower pressure. Your patient might feel dizzy when they stand up, so it's important to educate your patients that if they're in a lying or sitting position, they should get up slowly. Another common side effect is fatigue and cold hands and feet, because less blood is circulating to the extremities. Sexual dysfunction happens. Patients don't always bring it up, but they care about it. So create space for that conversation. Now, here's the one that can really catch you off guard. Beta blockers can mask hypoglycemia in diabetic patients. Here's what normally happens. When the blood sugar drops, the body goes into panic mode and the heart races. That's tachycardia. And tachycardia is a warning sign. But beta blockers block that warning sign. So your patient's heart will not race the way it normally would if they were in a hypoglycemic state. So what symptom still gets through? Sweating diaphoresis. So if your patient is diabetic and they are on a beta blocker, teach them to watch for sweating, not just racing heart, as a sign their blood sugar might be low. 2 numbers, write them down. Heart rate less than 60, hold the dose. Systolic blood pressure less than 100, hold the dose. That's it. Before you give any beta blocker, take a full set of vital signs. If either of those numbers is below the threshold, you hold it and you notify the provider. Then you document what you found and what you did. Let me say those 2 numbers one more time. A heart rate less than 60 and a systolic blood pressure less than 100. You do not give the medication. You hold the medication and you notify the provider. This is critical, and it is one of the most common NCLEX traps around beta blockers. Never stop a beta blocker suddenly. Here's why. When your body's on a beta blocker for a while, it adjusts. It actually grows more beta receptors to compensate, trying to get around the blocker. Now imagine you yank the medication away suddenly. All those extra receptors are wide open, and adrenaline floods them all at once. The result? Rebound tachycardia and rebound hypertension. And for patients that have a heart disease, this can be a very real risk of heart attack. So if your patient tells you they ran out of their metoprolol a week ago and just didn't feel it, that is important to note. That goes immediately to the provider. The rule: always taper, never stop cold turkey. Let's talk about what your patient needs to know when they go home on a beta blocker. First and foremost, they should take it at the same time every day. Consistency matters with this drug. Second, don't skip doses, and do not double up if you miss a dose. Third, if you feel dizzy, lightheaded, or notice your pulse feels really slow, call your provider. Fourth, and this one is the most important, do not stop this medication on your own. If you feel better, even if you run out, contact your provider before stopping. One more thing. Those over-the-counter cold medications, a lot of them contain decongestants that raise your heart rate and blood pressure. That works against what the beta blocker is doing. So tell your patient to always check with their pharmacist before grabbing anything off the shelf. Okay, NCLEX tip time. Here's the scenario. A patient has asthma. The order is for propranolol. Stop. That's the trap. Propranolol, remember, is a non-selective drug. It blocks beta-2 receptors in the lungs. In a patient with asthma or COPD, that can cause bronchoconstriction, which can be very dangerous. So non-selective beta blockers are contraindicated in asthma and COPD. The correct nursing action is to question that order. Don't just give it. You clarify first with the provider. These questions are testing your clinical judgment. They want to know, can you look at a drug, look at a patient, and spot the mismatch? And the answer is yes, you can. So we just covered a lot of ground, and I know that can feel like a lot to hold in your head. Here's what I want you to do. Head on over to my Etsy website, KadieKloset. The link will be posted in the description. I have a cardiovascular pharmacology study sheet that has all of this in one place. The cardioselective versus non-selective breakdown, hold parameters, side effects, patient teaching, all of it. So print it out, save it on your phone, bring it to clinicals. You worked hard to learn this, so make sure you have the resources that help you to keep it. Thank you so much for staying with me throughout this video. Please like and subscribe, and I will see you again in the next video.